Hello and welcome to the Scouse Science Podcast. My name is Professor Tom Solomon. I'm here at the University of Liverpool, where I'm a Professor of Neurology and Director of the UK's Emerging Infections Research Unit. And my guests today are BBC Merseyside's Roger Phillips and the University of Liverpool's Professor Louise Kenny. Say hi, guys.
Hi.
Hello. Hello.
Thank you both for joining me on the podcast. First of all, we have a little bit of housekeeping, so bear with me. We have people watching on Zoom, and if you're watching on Zoom, we want you to turn your camera off. And then also, I'll just talk you through this slowly. There may be lots of boxes with people's names on the Zoom meeting. So if you go on any of the boxes and right-click on the three dots in the top right-hand corner, and where it says, what does it say? Hide non-video participants. And if you do that, then all those boxes will disappear and all you'll have is our three smiling faces. So just do that now, please, and then everything will be in order. And a couple of other things. We do want you to join in, so you can go on to the chat function and send in any questions or comments there, and we'll feed some of your questions and comments in as we go through things. Also, there are people watching on Facebook. If you're watching on Facebook, you can post your questions there and they will be fed in. And also, I have my Twitter account close to hand. So if you tweet me at RunningMadProf, any questions or comments, we can feed those in as well. Now, why are we doing the Scouse Science podcasts? Well, we spend a lot of time talking about science, certainly I do, on the radio, on television, and they're always very short interviews, those, and it's clear there's an appetite for a longer discussion and perhaps a bit more relaxed environment. So we decided to get together with some of our leading scientists here at the University of Liverpool, and we also wanted to think about the wider impact of some of the work we're doing. And so we've always, for every podcast, we choose one of our famous faces to join us and help in the discussion and to keep it grounded. So, Roger, that's your role. Keep us grounded.
Oh, God. How do I do that? Louise couldn't possibly be grounded, and you never could be grounded.
I think you spent years keeping people grounded on BBC Radio, haven't you? So, well, let me introduce today's guest properly. So, Roger Phillips was born in Manchester. I didn't know this, actually, until we started doing a bit of homework.
To my embarrassment.
Yeah, you went to Cambridge University to study medicine.
Yes.
Roger, what happened?
Well, I'm the science expert, obviously, of this podcast. No, what happened was I didn't like cutting up bodies, to be frank, and also I found the whole thing really boring. So I switched to English.
And you've never looked back since. Louise, how were you with the cutting up bodies when you did medicine here in Liverpool?
I had absolutely no problem with it, which probably speaks volumes about me. Yeah, at 18 though, I think it is one of those sort of do or die moments. If you're 18 years of age and you walk into the dissection room and you're confronted with 30 dead bodies, it is one of those moments that, yeah, and the smell, the formaldehyde, yeah, and even now, I mean, it's been 30 years since I was in a DR, but the smell of formaldehyde takes me back to being 18 and standing there in a white coat with my scalpel. Yeah, it's quite a key moment.
Can you remember the name of your cadaver? So for those who aren't medics, you get a year to dissect a body slowly throughout the year, and ours was called George.
Ours was Harry.
Harry. No idea what ours was, because I started not going because it was split. The body was split into two, so the four of us working on it. There's probably cheapskate Cambridge, I know. And my partner, well, he did all the work. I got fed up, and he just did all the work. So I only met my body about twice.
Okay, maybe if you'd known your body's name, you would have developed a better relationship and you would have stuck with it.
Yes.
Anyway, you read English, and then you came to Liverpool in the 70s to join the Everyman Theatre, and you've really not looked back since. You've been here ever since and got involved with the radio, etc.
By accident.
And by accident, yeah. The Everyman Theatre in the 70s, I think there were some quite well-known people involved then. Is that right?
Gosh. Oh, yeah. I'm still in touch with quite a lot of them, actually. Matthew Kelly, Julie Walters, Bill Nighy. I mean, the list is pretty enormous of really good actors who were at the Everyman in that period of time, and they all, although some are not so well known, they've all gone on to do fantastic work. Although at the moment it's really, really difficult. Actors are not having a good time at the moment because they're all freelance, obviously. There's no support for them.
Yeah. Do you keep in touch with any of those guys?
Yeah, indeed. I was talking to John McCardle last week, Matthew Kelly last week, Bill Nye last week. Can't remember, but I'm retiring, and part of my retiring is to take me away from Liverpool 5 days a week, because I want to be able to go and see some of these people who I've not seen for ages. So that's part of it. So I'll see more of them.
Yeah. Now let me just introduce Louise properly. So Louise is the Executive Pro Vice Chancellor of the Faculty of Health and Life Sciences at the University of Liverpool. She's my boss, my direct line manager. So I will behave.
I'm not a scary boss though, Thomas.
How do you know? How do you know? We may all be terrified of you.
Probably not for me to say.
We were too terrified to tell you.
Noted.
She's also the Deputy Chair of the Board of Liverpool Health Partners, and she was founding director of the Science Foundation Ireland funded Irish Centre for Fetal and Neonatal Translational Research. And that's really what your research has been on over the years, hasn't it? Maternal and child health.
Yeah, absolutely. So I'm by day, and what we actually say in our profession is usually by night. I'm a jobbing obstetrician, so I specialise clinically in the management of high-risk pregnancies, and that's been my research focus for almost 25 years now. And
are you still managing? I mean, you're running the university, you're running the research response to COVID-19 across this city. Mm-hmm. Do you still manage to do any obstetrics or gynecology these days?
Yeah, a tiny bit, but you'll appreciate that the day job that I currently have is quite substantive, and it's become more complex with the pandemic. But I do keep my hand in, and I've still got a very active research group that is researching a variety of different things in pregnancy, some of which we're going to talk about today.
Yeah. So clearly, the scientific topic of the day, of the week, of the month, of the year is COVID-19, the coronavirus. Roger, you were talking a little bit about how it was affecting people, people in acting, etc. Yeah. Just tell us a bit more about that.
Yeah, I mean, people are very upset. I'm broke. Acting life is, although we mentioned names such as Bill Nye, who makes a lot of money. There are an awful lot of really, really good actors who don't make that much money. I mean, somebody I was talking to was Graham Seed. He used to play in The Archers, and he lost that job. He was pushed off a roof, I think.
Oh, yeah.
Nigel Pargeter is the character he played. Lovely actor. He was actually my daughter and my wife when we were at school. He played Ophelia and Gertrude. So I have close relationship with him, but nevertheless, he's a really good actor. He gets lots of work, but then suddenly the work stops, income stops, and there is no support because dear Mr. Rishi Sunak, I'm afraid, forgot there was 3 million people in his sort of situation. So although the furlough scheme is great, it's not done them a lot of good. As regards me, it's been great for me in a way because I work from home. And as I come coming up to retirement, in a sense, my wife's had to put up with me in a way that she never has had to in the past, sort of. So it's kind of led me into having an easier retirement, perhaps, or semi-retirement, than I would have done.
It sort of transitioned you into it because you've been spending a lot of time at home.
Absolutely.
And your wife has not been trying to convince you that maybe it's not time to retire and you should go back.
She knows I'm going to be away quite a bit doing other things, and great relief at that. But I was going to ask you, Louise, she had a difficult birth, or at least the first one, and she was in this ward, and they couldn't work out what it was. I can't remember the detail, but they couldn't work out. Eventually, they sent her home, and the GP, a brilliant GP, diagnosed with something called Bornholm's disease. Now, I don't know if Bornholm's is directly related to pregnancy, but it was a problem. She went back into that special ward at it was Oxford Street in those days.
Oxford Street, yeah.
And had a great birth, and we did a domino. Do dominoes still exist?
Absolutely. Dominoes is a domino delivery, which is, for the listeners, it's a package of care whereby you have all your antenatal care with the same midwife or small team of midwives. And you come into the hospital, but the team of midwives that have been providing the antenatal care come in with you, provide the care in the hospital, and then when you're transferred to the community, the same team come with you. So you get that wraparound continuity of care, but with the safety of a hospital delivery. So it's perfect, particularly for first-time mums.
That was great. She's the same midwife, both children.
Yeah,
she was
perfect.
brilliant.
Yeah, I had my first baby in Oxford Street, actually, just before it closed down. And I also had domino care. And for a young first-time mum, it was perfect. Yeah, really, really. But these days we're increasingly, when I trained back in the early 90s, obstetricians tended to frown on home delivery. But we now know that the data around home delivery suggests that it's actually really safe. And I've spent the last 10 years prior to coming back to Liverpool advocating for better antenatal care and extending choice in Ireland, including provision of home delivery, which is still not a common option in Ireland.
It's quite useful, however, for the home to be close to the hospital. And I'll tell you why I say that. My daughter, who's now he's coming up to 3, when he was born, it was a real problem because... I'm sorry, I've lost you. I don't know you got me still. Have I lost you?
We have. No, we've got you. We've got
you. Carry on.
I've just got unfortunately. I've just declined a call. Sorry about that.
I forgot to warn you all to turn your phones off. How many years have you been broadcasting, Roger? How many years broadcasting and you still don't turn your phone off?
I'm very bad. Well, I can't see you for some reason, but anyhow, I forgot what I was telling you about. Oh, I know, yes, my daughter Alice. She had this baby and she was having a home with a home birth, and in fact with a water birth. They got in a water birthing, and she had a very, very long labour, and eventually it was dangerous. Literally, they live 5 minutes in an ambulance from the hospital, so she actually delivered in the hospital, but it was really useful to have that safety of the hospital.
Mm-hmm. Yeah, absolutely. I mean, it's not a straightforward black and white issue, and there are layers of risk and things. But in general, I'm a huge advocate for choice around birth. I think we need to be able to offer women a full range of options that suit them and their families.
Yes.
How much, Louise? How much have things changed during this pandemic in terms of the kind of care being offered and how it's affected pregnancy and deliveries, etc.? Well,
hugely, right? So. For example, I think telemedicine has really come of age during this pandemic. So in obstetrics particularly, because if you sort of remember that pregnant women aren't actually sick, they're not patients, and largely they don't need to come to hospital. They can have the majority of their antenatal care done safely in the community. But there's always been that reluctance, I think, amongst certain diehard professionals to relinquish control of the antenatal care into the community. And of course, what the pandemic's done is it's made that absolutely critical. We now have to provide antenatal care outside of the hospital setting, because to do so otherwise would not be in women's best interests. And then other things like provision of safe early termination of pregnancy, that can now be done by telemedicine with the modern drugs that are available. So it's been hugely advantageous from that perspective. I think it's really through not by design, but just by happy accident. It's actually made women and their families and their actual needs the focus of care in a way that it's accelerated what I think was inevitable, but happily it's now become mainstream.
And are things beginning to move back towards normal, do you think? We've lost Roger, by the way. I don't know if we've just lost your video, Roger, or if we've lost you completely.
Hopefully he'll dial back in a minute.
Okay, we'll carry on and he'll read.
Yeah. So this is the thing, right? So pregnant women aren't sick. They're usually happily for the majority of women, pregnancy is just a normal physiological life event, and language like patients and hospitals and things is not really appropriate. But there are some issues in pregnancy, and one of them is that a normal response to pregnancy is that the immune system, and you'll know all about the immune system, Tom, is actually turned down slightly. And the reason for that, and that's a normal response, it happens in all healthy pregnancies. And the reason for that is the way I sort of describe it to our medical students and my kids is that if I were to take, for example, your kidney, Tom, and implant it in me for a kidney transplant, chances are, as we're not related, we wouldn't be a match, and I would reject that kidney. But in pregnancy, a woman can grow a baby that is at least half antigenically foreign, half the genes, half the proteins, half the antigens belong to her partner, belong to the baby's father, and they're foreign to the mum. And in the vast majority of pregnancies, mums don't recognise that. They have what we call the immune privilege or immune tolerance of pregnancy. And that's because their immune systems are turned down a tiny bit. And that underpins healthy pregnancy. And it's great, except for during things like a pandemic, because that means pregnant women are far more vulnerable to things like influenza. If pregnant women get diseases like varicella chickenpox, they can get very severe doses of it. And so it becomes really problematic at a time of infection. And that's why, quite frankly, myself and my colleagues were, when coronavirus first popped up in early January, the whole obstetric community really braced themselves, because we had a very unfortunate time during the last pandemic, the last significant pandemic, H1N1, back in 2009, 2010. That was really hard for people in my profession. And for the women that we care for, because pregnant women did very badly during that pandemic. And that was our experience. So we braced ourselves for something similar during COVID.
But it hasn't happened. I mean, my understanding is there hasn't been the big. So the other recent pandemic or epidemic was Zika virus, which we were heavily involved in from the university. And of course, with Zika, which is a mosquito-borne virus that caused big outbreaks, especially in places like Brazil, the big problem was congenital disease and all these children being born with abnormalities and some dying in utero, etc. But I think for COVID, we haven't quite seen that, have we? Not
at all. So, I mean, there are two challenges when you look at any infection or any other disease process in pregnancy. Firstly, there's essentially two patients. You have the effect of the disease on the mum, and then the effect of the disease on the unborn baby. And then the second thing is that pregnancy itself, because of those huge physiological changes that we just talked about, pregnancy can actually affect the course of the disease. So it's quite a complex situation, and we didn't know which way it was going to roll, as it were. But early data from China, from Wuhan in particular, was very reassuring. We didn't see huge numbers of women being hospitalised, pregnant women being hospitalised with COVID. And critically, the thing that we noticed very early on is that whilst women may be actually getting the disease, they're picking up COVID, they were not really getting the very severe phenotype that we're now very familiar with, of this complex sort of huge multi-system disorder that inevitably results in admission to ITU and huge system collapse and organ failure. Very, very few pregnant women got that kind of disease endpoint, and the ones that did tended to have other additional risk factors, including pre-existing diseases or obesity or complex, a complex mix of the two, or they came from ethnic groups that we knew were at particular risk. So that piece is reassuring, and we can talk in a minute, I guess, about some of the theories around why that might have happened. Of course, the longer term effects, what COVID has done, catching COVID in pregnancy, what that does to unborn babies remains to be seen. But certainly the early data is reassuring. I mean, with Zika, which you correctly flag as had a devastating effect on the babies of mothers who contracted it during pregnancy. But so far, touch wood, I mean, and it's still very, very early, we haven't seen any strong signals that COVID causes any specific problems for the unborn baby.
Yeah, and it's interesting. So you were, on the one hand, you were, and Roger's back. Was it all talk of deliveries? Was what was upsetting you?
Put me right off.
Yeah, it can be like that for some men. I understand, but don't worry, we're not in the delivery room anymore.
Thank goodness.
We've moved up. But Louise, you it's interesting because on the one hand, you're talking about the rights of women to have home births, and it sounds like Ireland was quite different to England in that sense, and community births, etc., and the fact that these are not patients, they're just people with babies. But then on the other hand, your research has been on I think when pregnancies have gone wrong, hasn't it, and on the risk groups.
Yeah, so I specialise, for the last 25 years, I've been specialising both clinically in providing care to women and also researching a condition called preeclampsia. So it's relatively common condition, and in fact, there've been a few things that have happened in sort of popular culture in the last decade, which have really raised the profile of preeclampsia. So any listeners or watchers of this event or listening to the podcast will hopefully be familiar with Downton Abbey. And Lady Sybil, one of the key characters in Downton Abbey, actually died of preeclampsia, eclampsia, or toxemia of pregnancy. It used to be known back in the 1920s. And then, of course, there've been a variety of other high-profile celebrities who've also had preeclampsia, including Kim Kardashian, who had quite severe preeclampsia in her first pregnancy. So it's become much more mainstream and much more well known. It's actually a relatively common condition. It affects about 3% of all pregnancies, and globally, it is a leading cause of maternal mortality. Happily, we don't often see pregnant mums dying in high-resource settings like the UK, but through the world, and particularly in some of the areas in sub-Saharan Africa where I've previously visited or worked, it accounts for about 72,000 deaths every year of pregnant women. And when you think about that, Tom, you're talking about, by definition, young women, because you have to be relatively young to get pregnant, and healthy women, because in a low-income setting, you have to be relatively healthy to conceive. Okay, so these are young, fit, healthy women at the start, and it nearly always is in first-time pregnancies, at the start of their reproductive lives, and they die of a condition that we've known about for literally millennia. Hippocrates wrote about preeclampsia, but we still don't understand it, and we don't have a cure.
Yeah, I think certainly some of the overseas places where we work, you do still strikingly see many of these conditions that we don't see at all, or very rarely in the West. Have you, Roger, in your career, have you travelled overseas much or worked overseas at all? Or is it in your plans for the future?
It's certainly in my plans for the future. No, I haven't. But can I ask about preeclampsia? You say you haven't found a cure. Well, it is treatable. No,
so that's a really frustrating thing, Roger. So
people don't die of it.
So 72,000 women die every year. The reason why women in high resource settings don't die of it is because the only cure, as it were, is delivery of the baby. And so in a high resource setting like, the Liverpool Women's, where we've got an absolute world-class neonatal intensive care unit, I can make, quite bold decisions at 29, 20, 28 weeks gestation, and I can save the mum by delivering the baby early, knowing that my neonatal colleagues will do their best for the baby. But if you make the same decision in a low-income setting, it's a death sentence for the baby, and it may not save the mum, because mums often need a whole amount of supportive care around that delivery that is very difficult to offer in a low-income setting. So it's the only cure is delivery. There isn't a drug or any other kind of treatment that will make the condition go away. And it's something that my group and my collaborators around the world have been working on for decades now. But it's a frustration of ours, and Tom has probably heard me talk about this on numerous occasions. Preeclampsia only affects women, and it only affects pregnant women, and so it's often seen as a minority disorder. And I've stood in front of grant-giving bodies over the last 2 decades and have been told that it only affects women and it only affects pregnant women, so it's not really that important. And I now say, if ever anyone says that to me, I now say, well, how did you get onto the planet? Because unless it was by a pregnancy, and you've discovered another way of making your entrance into the world that I'm not familiar with. So, and if you are the baby born of a complex pregnancy, you carry a legacy with you for the rest of your life in terms of adverse health outcomes. So I'm passionate about raising the profile of this disease and related pregnancy disorders.
I've heard of it. What is it? What does it mean? What's the clamp it's pre of?
So it's the old-fashioned name for it was toxemia of pregnancy. It used to be known as toxemia of pregnancy because it was thought back 100 years ago that there was a toxin, some sort of poison in the maternal bloodstream that attacked the lining of blood vessels and caused the blood pressure to go up and cause the blood vessels to leak, so women swell up and get what we know, edema and swelling, and it causes renal failure and lots of other organ failure. The honest answer is that we still haven't completely nailed the actual etiology and cause, but we absolutely are certain that there is a toxic substance or substances in the bloodstream which cause endothelial or blood vessel dysfunction. And the theory that my group and I are currently working on in collaboration with Professor Doug Kell, who's a colleague that I've known for many years, worked with in Manchester previously, and happily for us, he's now joined us in Liverpool, is that toxin actually is an infection. It could be one bug or several bugs, lots of dormant bugs, but we're currently working on a hypothesis that actually it's a low-grade infection that leads to this complication.
So you're not got any genetic connection with it, isn't it?
Yeah, well, so there isn't a preeclampsia gene, Roger, but previous studies have shown that if your mum or your sister has preeclampsia, and don't forget your dad and your brother can't get it because you have to be pregnant to manifest the disease. But if your mum or your sister has had preeclampsia, you're between 2 and 4 times more likely to get it yourself than the background population. But we've gone looking for the preeclampsia gene and we can't find it. So it's probably like type 2 diabetes. It's what we call a polygenic condition.
Maybe with an infection trigger like
exactly,
diabetes.
Yeah. You need the right set of genes. But the other really interesting thing is the baby's genotype. And don't forget, the baby's genes are half the dad's genes. That's also critical. So it's kind of like a mismatch between mum and baby that causes it.
Wow.
Let me bring in some questions, and also I should have said to our audience, but I didn't, so apologies. We usually get everyone at the start just on the chat function to just send in a message to let us know where they're listening from and whether they've listened to any previous episodes. So just send that message in now if you haven't sent any messages in. But meanwhile, here are some questions. There's a question around immunology relating to SARS-CoV-2 and innate immunity, and whether in preeclampsia the immune responses are thought to play a role, I think.
Absolutely. So this is the fascinating thing. So when we didn't see women manifesting the sort of what we now call the cytokine storm in very sick people with COVID, pregnant women just didn't seem to manifest that cytokine storm. They weren't getting really complex syndromes. They weren't ending up on ICU. And one theory is that because they have in a healthy pregnancy, their immune system is ever so slightly dysregulated, toned down. That's why they weren't developing the cytokine storm. So that's one theory we're working on. Another theory is that, in fact, when you look at COVID statistics globally, far fewer women than men get really complex disease. A significant majority of the patients who end up on ICU and in the mortality statistics are men. But that protective effect of being a woman disappears after the menopause. So another theory that we're looking at is that actually estrogen, which is very, very high in pregnancy and higher in women than men prior to the menopause, is somehow protecting women from that, from developing this sort of severe phenotype of the disease. And we know from studies that we've done previously that an array of hormones, including estrogen, but also testosterone and other hormones, do modulate the immune response. So that's something else we're investigating at the moment. Yeah.
I've got messages here from people, someone who had preeclampsia herself and whose son was born by caesarean section. Not always possible, not always easy in overseas settings. She's in the UK, but we've also sent someone messages coming from Kenya, somebody listening there. So we have people from all over the place listening to this. Let's move on from preeclampsia. Let's just think a little bit more about this COVID problem and the impact that it's been having on us all. Roger, you talked about the impact on your acting friends. What about at BBC Radio Merseyside? How have they coped with it? Has it, apart from them being relieved from having you in the office every day, which I'm sure was a great pleasure for them?
Absolutely. Well, the BBC decided we must only have a certain number of people in any building. So I think it's 5. I've not been in, but I think it's 5. So only 5 at any one time in a building which normally holds about 40. And there's a one-way system through the building now, and there's, sanitizer everywhere. So people are working from outside the building, which has worked relatively well. As I said, I've broadcast for the last 5 months, whatever it is, from here, from where I am now. And a very simple system. So that's worked well, and it will be used, I'm sure, in the future. But what they panicked a bit, particularly in terms of local radio, so they got together, all the local radio stations have exactly the same programming. So it was a 4-hour programming as well. So 6 till 10, 10 till 2, 2 till 6, 6 till 10. The idea behind that was early on, nobody knew whether everybody was going to catch this thing, so they could have teams, by using 4 hours, they could have teams of more than one presenter and more than one producer working on them to fill in. And also, worst came to the worst, I think Stoke was our buddy station. You'd have a buddy station which would actually be able to take over that 4 hour block or whatever it is. So that was a good idea. And because they didn't know what was going to be going on, they decided that they're so wonderful that they carry it on. I can't say that everybody's pleased about the idea of 4 hour programs, but I can understand the BBC's got to save and cut money and so forth, and it's a cheaper way in the end of probably doing things. It's not been great then.
So they're not there. Yeah, I mean, quite a lot of the response locally, nationally, it's always easy with hindsight, isn't it? You're sort of damned if you do, damned if you don't.
Correct.
I mean, I guess we similarly, when things were at their worst, you kind of think, what really, if we are massively depleted in terms of staff, how thin could we get on the ground? Thankfully, for the most part, certainly in the Northwest, things never got as bad as we feared.
Nor would it be.
No, and I think that's partly because the national lockdown came in response to London's problem, effectively.
Yes, that's
things
correct.
Things were a lot worse there, and they really did need that.
Mm.
But they're not now at the BBC. They're not now going back to trying to get back to where they were.
No, I'm sad about that, but that's their decision. Fair enough. I don't think it's the best decision from the point of view of the listeners. But I may be wrong. It's a long time to be broadcasting. 4 hours is a long stretch, and to keep yourself, 5 days a week, 4 hours a day. It's actually, mind you, you're digging up holes as a labourer, and you do 8 hours a day.
Mm.
You know what I mean?
What's a normal shift? Is it normally a 3 hour program, or what? It used to be 2 hours.
Maximum 3.
Yeah.
Some 2.5, 3.
Yeah.
And that's when you're on air. There's a lot of work around it, of course, as well, pre-recording, planning it, and so forth. And that's all worked remarkably well with Zoom. Actually, we have I don't now, but there is a meeting every day, a Zoom meeting with people joining in. There's just a phone contact meeting in the morning as well. People run through what we've got on and so forth. I think what it's probably, and I'm not sure this is true, it's more me thinking this. We've not been able to react as well to news as we did in the past. We couldn't rush out and do a job, if something happened. And that means that we're not quite as good. I think we'll get back to that, however, because there'll be more freedom as we go along. But it's not been great to have, of course, in another way it's been great, because great stories for us to tell. So in that respect, it's been wonderful,
Yeah, there's certainly been a lot going on, hasn't there? What about, Louise, you've been responsible for a lot of the response at the university. Have you been pleased with the way things have happened, or, things that you haven't gone the way you'd have wanted?
I think on the whole, I've been really pleased, Tom. So, as you know, our university has significant strengths in infectious diseases research. You're one of our superstars in that area. And so when this first started to unfold in early March, we were, I think in a sort of pole position, and were able to corral a lot of expertise, a lot of homegrown expertise, a lot of resource, and we were able to pivot really quickly to becoming very COVID facing and COVID focused. So in early March, just before the national lockdown, actually, we made a decision to flip the classroom and go online. And we closed down our campus to all but COVID related research. And that ramped up very quickly, so that if you walked onto the campus in late April, you wouldn't be able to tell the difference in terms of, the laboratories, because they'd gone from, concentrating on cancer and cardiovascular disease and all to face, on COVID related problems. And the university really led the city response in coordinating that. We managed to raise or repurpose over £1 million worth of funding, which, Tom, you helped us allocate through extensive peer review, to pump prime projects that then, many of which went on to gain national funding. We started to help colleagues nationally and internationally with things like the vaccine trials. We've been working to support our public health colleagues in sort of beefing up our testing capacity, so that we can make sure that test and trace is as efficient as it needs to be, particularly with the return to the campus in a few weeks' time of our student community. So yeah, we've had a very, very busy pandemic, but I feel very fortunate because I obviously know many of my colleagues in similar roles elsewhere in the country and other universities have not had the expertise that I've had at their fingertips. I mean, I've had, Tom literally at the end of a phone whenever I need him. We've had Callum Semple, who sits on stage. We've have an array of the brightest and best minds in infectious diseases research. And it just so happens they work for the University of Liverpool, which has made my job incredibly easy. I feel very lucky.
But Louise, is there a problem that all that research, and I know how much research does go on at the university, which has been diverted to COVID, is that going to set back research on cancer, research on eclampsia? You know what I mean? Is it going to set back?
No, absolutely. It has unequivocally, Roger. So, a good example is that shortly before, at the back end of last year, we were awarded a huge grant to establish a new birth cohort in Liverpool called Seagull, Children Growing Up in Liverpool. And this will be the first birth cohort nationally for 20 years. Now, that birth cohort should have launched at the back end of this year. But when lockdown came, we had to pause all of that effort, partly because I'm leading it and I was busy doing something else, but also because the team engaged on that programme were helping do a myriad of other COVID-related research programmes. So unequivocally, research in other areas has been set back, and it's something that one of our big funding bodies, the National Institute for Health Research, NIHR, are very exercised about, because we're now restarting all those research programmes and those trials, and we're doing that in parallel with continuing our COVID research and anticipating a second wave. So it's a really complex endeavour, and a good chunk of my working day right now is devoted to how we can get our other research programmes back on their feet, because they're critical. COVID has been unequivocally a global tragedy, but in a city like Liverpool, where we have very high unmet health needs, high levels of cancer, high levels of cardiovascular disease, huge mental health issues, all of the work that we were doing in those areas, which is vitally important to our citizens and something that the university are enormously proud of, has been paused. And so we have a moral and ethical and, quite frankly, a clinical imperative to get that back up and running.
I tell you one good thing that's come out of this, I think, is that people who didn't know what goes on at the university, what is this research stuff, they'll suddenly start thinking, I hope, teenagers at school will think, maybe science is for me. Maybe I can help with these things in the future. Yeah. That's one positive I can think of.
But I think you're right on that, Roger. But one thing that's really struck me is how little basic science people know. I was talking with Jane Garvey, who does Woman's Hour.
I know Jane well.
Yeah. In fact, I think she's coming on this Scouse Science podcast next month.
Great.
But she was saying how much it's made her realise how little she knows and how little basic scientific understanding people have. Just the basic concepts, even things like trials, the idea that you're randomised to one treatment or another to determine whether it works, and just saying, here's somebody that had the drug, they're now better. Looking at an individual doesn't answer the question.
Sure.
The thing, in terms of radio, so the thing that always horrifies me, not about Radio Merseyside, of course, which I love, but the Today programme on Radio 4, they so sorely lack having any of their anchors with any scientific background.
I know.
They have clones who all got the same background, and therefore they've got nobody who can have a sensible discussion about anything vaguely scientific or medical. And I think that's really become clear, when you listen to Radio 4 in the morning, if you do.
I couldn't agree more, actually, Tom. And my frustration is that, and someone's just put this in the chat, right? They love the fact that Roger is still in journalist interviewer mode and asking great questions. Yeah. And it's really difficult, because I've done the Today program, as I'm sure you have, Tom. And if you're not asked the right questions, it's very difficult to get the right facts across. And yet, I think Radio 4 consistently underestimates the intelligence of the audience, because they get economic experts on and people talking about, the economic recovery, etc. And they assume a level of macroeconomics that I think the average listener probably can get their heads around. But similarly, I think the average listener, with enough time and the right questions with the right responses, can absolutely understand the benefit of a randomized controlled trial and the value of science to this response. So couldn't agree more.
Two things about that. One is, if you're asked a question by anybody, ignore the question and just get across the scientific point that you want to make. That's really, it's a basic when you're being interviewed. The other one is, just before this podcast, I listened into a Zoom thing from Tim Davey, the new Director General.
Mm-hmm.
I think it might change. One of the things he was saying is we are too restricted, too narrow. We appoint from ourselves. He didn't say it quite as bluntly as I'm saying it, but basically, I think he wants to get scientists, economists actually presenting the programs, not being the interviewee. And so I think it may improve somewhat. But it is I was always dead lucky. By sheer accident, I did science up to the end of my first year at Cambridge. Then I did arts. Then I was a taxi driver in Liverpool. All of this came together quite accidentally to enable me to do the phone-in. It's extraordinary.
Well, I'm sure for you, having that kind of broad background does help, and it does make the phone-ins work. That I guess is why they've worked so well, compared to some other kind of interviews that you hear and see on the radio. Mm. Let me feed in a little bit more of the discussion from our panel of experts. The editor of today has an agenda that doesn't include these kinds of things, science. No, I think that's probably right. I mean, Roger, actually, what you said about just don't answer the question, just give the answer that you think people. But I've been doing quite a bit on the media recently, and my brother, who is my biggest critic, slates me off terribly for not actually answering the question.
Why should you?
Well, he says answer the question first and then make the additional points you want to make.
Listen to politicians. They'll say, that's a very good question. And then we'll answer what they want to answer.
Jenny Morris, who's well known to me, has said exactly the same. The politicians just answer the question that they want to.
Absolutely.
Let's see. Now, Dan, where is Dan? I'm just flicking through. Oh, yes. Dan Wootton, a previous guest on the programme from an earlier month, has sent in this rather naughty question, Dan, so I think you should behave, but I'll put it out anyway. Dan says, working from home doesn't always mean working. What's happened to pregnancy rates?
Well,
anyone want to comment on that?
I would be happy to comment, Dan, and you are in fact correct. So we always, in my world, we always brace ourselves for September, which is 9 months after Christmas and New Year, and every September, it's almost the stuff of it's apocryphal, but actually the statistics bear it out. There's always a small uptick in the birth rate in September. Most units do see a very busy September, and similarly after things like very harsh periods of weather, the big snow of I think 2010 led to an increase in the birth rate 9 months or so after that. Things like a successful cup final in Liverpool often lead to there are local things that can happen that lead to a small uptake in the birth rate. But yeah, I think my profession as a whole is bracing themselves for a very busy Christmas and spring of next year, because lockdown did lead to a lot of couples spending a lot of time together, and that can go on all
murdering each other. If my house was anything to go by, and I wasn't even locked down. I've been working.
I gather that divorce lawyers are also going to have a very busy time. It's going to go one of two ways.
Now, we've slagged off Radio 4 Today programme, which is always a good thing to do.
Yes.
But I want to finish. We're meant to finish at 1:45, but I want to finish by just drawing attention to awards that both of you have won, and you've both won enormous numbers of awards. But for each of you, one in particular stands out. And for Roger, I've dropped my notes. Let me see if I can find it. You'll probably remember. Yes.
I hope it's the one I really liked, the one I really enjoyed. But
go on now. You know what I'm talking about. Tell us all about it. It's the Sony one,
yeah. I love it not because I won the award, because I beat. Let me think. Remember, Andrew. What's his name? He was on 5
Andrew Neil.
Andrew Neil was on 5 Live. The Women's Hour team, if I remember correctly. The whole team, and Peter White. And the main point is, it was really funny. We sit there at the table because you come down, and they have 5 in the Sony. You have 5 shortlisted, and 3 will get something wrong. So I was ticking off. Oh well, we've not won then. And then, unbelievably, I won. So that's the one that matters, not because it's a award, but because I beat the others on Radio 4. And I've always thought local radio far more important than national radio.
Yeah, thank you for that. But the one award you haven't won is, I don't think you've won Tatler, Irish Tatler magazine Woman of the Year. Roger, what happened? Why haven't you won that?
The Echo ridiculously once put me in one of the top 10 metrosexual men on Merseyside. Now, what the hell that means, I don't know, but I was very pleased to get it. I bet you didn't get one of those, Louise?
No, I didn't. No.
But Louise, you did get Irish Tatler magazine Woman of the Year.
That's good.
I did, yeah, and that was great. I think for the same reason, actually, Roger. I didn't expect to win. I thought we were just making up numbers at the dinner, and I took my lovely parents, my lovely mum and my late great father with me, as well as my husband. So we just thought we were having a jolly night, in a nice hotel, and I won, and it was actually an award not for anything that I'd done clinically or scientifically, but because of various campaigns I'd been involved with to increase the quality of access for women for basic healthcare and reproductive rights in Ireland. So I was quite proud of that, because getting an award for the job that you do and love and are good at and are paid to do is kind of like, but getting an award for something that you sort of do in the margins of your spare time, and it gets recognised, it meant a lot. And it was because, the women that I'd actually been campaigning for were behind it. So the value of it is immense.
No, it's really well deserved, Louise, because you have affected, the work you've done has affected so many women in Ireland. And I'm aware of many people who have, well, it's changed. The whole thing has changed in Ireland because of what you've done. It's not just gay marriage, for God's sake, gay marriage. 20 years ago, gay marriage should have been Satan and devil and all of that. And now, people love each other, and it's brilliant. And it's down to the work you've done. It's brilliant.
Yeah, it's a change country and a lovely place.
Thank you both very much. Louise, thank you for the work you do for the Women of Ireland and the University of Liverpool and the City region. Roger, thank you for how many years of broadcasting? 20 plus?
42.
42. Based on your performance today, I think there's life in the old dog yet, so I wouldn't quite hang up the microphone yet. Thank you to all our listeners for tuning in. I should let you know that you can go to the Scouse Science website to hear this podcast again or previous podcasts. Let your friends know about it. We are actually now a proper podcast if you go onto Apple Podcasts or the place you normally look for them and put in Scouse Science into the search engine, you'll find these podcasts. Amazing. And if you listen to them, rate them, review them, and do whatever else people do on podcasts, and then we will get more listeners. I want to thank the IT team, particularly Jane Connor, Sean Winston, who are all in the background making everything happen very smoothly. And the next of the Scouse Science podcast will be on the 14th of October. We think it's going to be with Jane Garver from BBC Woman's Hour, plus one of our scientists from the university. But thank you very much to both of you. Let's all say goodbye now to our guests. Bye.
Bye-bye.
Bye, everyone. Thank you.